All right, hello everybody. My name is Amalia Weber. I'm the program specialist here at Rochester Hills Public Library, and I'd like to welcome you to this evening's Smart Towns program, Injury or Aging: How Trauma in the Brain Can Masquerade as Dementia. Before we get started, I'd like to take care of a few housekeeping details. Firstly, tonight's program will be recorded and available to view about 1 week from tonight on our YouTube page and on the RHPL website shortly after. We ask the audience members please silence or turn off their cell phones before we begin in order to avoid any disturbances during the presentation. Our next program is another Smart Towns presentation, China's Past and Present, which will be an in-person event on Tuesday, September 27th at 7 p.m. You can sign up for that at calendar.rhpl.org. Tonight's program is presented in partnership with Smart Towns, a lifelong learning program for everyone in the community, led by educational organizations in Rochester, Rochester Hills, and Oakland Township, Michigan. Smart Towns offers lectures, presentations, and courses that introduce the participants to all aspects of the topic and are presented by experts in their respective fields of study. And now, without further ado, please welcome our presenter, Jessica Matyas.
Thank you very much. I am Dr. Jessica Matyas. I am a specialist in neurotrauma, particularly with experimental psychology, and I work with Rochester University as the chair of their psychology department. I'm glad that you could join me here tonight. I'd like to talk to you about 3 particular case studies which look at traumatic brain injury, how that trauma ends up masquerading as dementia, and what we could potentially do to help resolve those cases. I'd like to start first with some idioms that may look familiar to you. Such things as, my memory's not what it used to be, I'm not getting any younger, I'm having a senior moment, I'm no spring chicken. One of my family's favorites, I've got one foot in the grave and the other on a banana peel. And in general, the passage of time is always cruel. Time makes fools of us all. Life is gone before you know it. As a culture, we seem preoccupied with age and getting older, and it's understandable to see why. As we age, we lose bits of ourselves. We slow down, we experience more pain and illness, we're forced to say goodbye to the things and people we once loved. And for ages, we've been searching for ways to turn back the clock or at least slow it down. In more recent years, discoveries have shown one major factor is related to most, if not all, of the cognitive changes we experience with age: brain damage. Whether it's slow and gradual or comes on suddenly, it's more and more apparent that the pockets of damage within the brain are responsible for a myriad of symptoms. So please join me in tonight's discussion where we will explore the connections between brain injuries and normal aging, including what we can do to slow down that clock. In particular, I'd like to point out this idiom here: you can't teach an old dog new tricks. By the end of this conversation, I think you'll agree that this idiom is ready for retirement. To get us started, I'd like to uncover the meaning behind a phrase we use a lot, or at least used to use a lot: going senile. There's a lot of clever euphemisms for this too, my personal favorite being their cheese has slipped off their cracker. But what does it really mean to go senile? Our definitions are that senility is anything pertaining to old age, and senescence is the biological decline that comes along with age. Together, going senile refers to both physical and mental decline associated with aging. But even with this definition right in front of us, it still might be unclear as to why we undergo decline as we age. The answer may lie in something that sounds even more terrifying than growing older: brain damage. There are, of course, some key differences between traumatic brain damage and age-related brain damage. Traumatic damage is usually more acute and has a clear origin point, such as falls, motor vehicle accidents, violence, even athletic injuries, and combat injuries that are sustained by veterans. Age-related decline, on the other hand, tends to be slower and less recognizable, coming from general decline, and diseases such as cardiovascular illness, diabetes, hypertension, the list goes on. Today we'll be looking at a few cases where the lines between them are blurred. To start out, let's think about the brain as a plastic item which can change shape and be remolded as time goes on. Much as we lose elasticity in our skin as we age, the cells in our brain also lose some plasticity and aren't able to bounce back as quickly. Among the many things that afflict us as we age, one that goes after the brain in particular is dementia, a very broad term describing a progressive decline in mental processes as a result of disease or injury to the brain. Dementia includes such subtypes as Alzheimer's, frontotemporal dementia, and cardiovascular dementia. Each of these, though, have a few symptoms in common, including memory loss being the key defining feature, personality changes, which particularly affects frontotemporal dementia, and impaired reasoning and impaired executive functioning. Of note, all of these are still also present in traumatic brain injury patients. But let's talk about memory decline first. The first case I want to talk about tonight is that of Henry Molaison, more commonly known by his initials HM. If you had taken an AP psychology class in school, you've probably heard of HM. As a child, Henry was in a bicycle accident. It's not clear exactly what happened in this accident, but he sustained a head injury, and as a result, began to develop epilepsy. When he was a young child, these began as absent seizures and began to get more and more severe. By the time he was a teenager, they had developed into grand mal seizures. And by his early 20s, he was taking 4 different medications to manage his seizures, which were still not reducing their frequency. These medications, of course, are not without their own side effects, and they were still not enough to prevent his seizures. So in 1953, when he was 27 years old, HM became the candidate for William Scoville's new, frankly experimental surgery. The goal was to excise or remove the parts of the brain where the seizures were originating. Theory being, if we remove those offending areas, the seizures will stop. Having few other options, Henry agreed. The original plan for the surgery was extensive. The targets included the amygdala, an area known for its role in emotional processing as well as memory, the hippocampus, highlighted in blue here, and the uncus of the temporal lobe, emphasized in gray on the right. Post-mortem, it was actually found to be less extensive than initially thought. It encompassed the polar cortex of the medial temporal lobe, up here, most of the amygdala, the entorhinal cortex, and the parahippocampal cortex areas adjacent to the hippocampus. During his recovery from his procedure, it became very apparent what these regions were all responsible for: memory. From this point forward, Henry was unable to form any new conscious memories whatsoever. He was, for all points and purposes, trapped in what the research team called permanent present tense. However, over time, researchers were able to find some islands of skill that he still retained. When I say conscious memory was lost for Henry, what I mean is he could not state outright that he remembered anything. This is a concept also known as declarative memory. That loss continued for the duration of his life, for 55 years after the surgery. Even when he had known a person for years at that point, he still could not clearly state that he knew them. In fact, in one adorable story from his time with the research team, he was asked how he knew one of the young women that was on the team. He admitted that he could not clearly remember her, but she did look familiar. Maybe we went to school together? The story also points out, though, that while he could not clearly remember, he did retain some sense of familiarity and learning. He was particularly adept at learning motor tasks. They had him do games like a target shooting game and rotary pursuit, which is shown here. In this task, he was needed to learn to predict where that target or disc would be moving to next, and adapt his speed and aim accordingly so that he could stay as close to the target as possible. As he trained in this task, he did show remarkable improvement, the same type of learning that would happen in somebody who did not have memory loss. Another task that he was shown to improve in was the mirror drawing task, shown here. In this task, a person is asked to trace along the outline of a shape without looking at their own hands, instead looking at their reflection in a mirror. Typically, when people do this task, it does require a bit more effort and concentration, but with practice, you get faster and more accurate with this. Sure enough, Henry also showed an increase in his accuracy and speed at this task. However, if you asked him, how did you do so well at this task, he typically would answer, I don't know, beginner's luck. Have you ever done this before? No, I don't remember ever seeing this. Must just be beginner's luck. Well, as you might imagine, having that much brain tissue removed had to have an effect on other areas of Henry's life besides just his memory. Those who ended up working closely with him, including most of the research team, noted that this included he didn't report as much hunger or thirst as other people that lived in his facility. He didn't feel pain to the same magnitude as others. And in general, his emotions were somewhat numbed. In all that testing, he was always friendly and cooperative, rarely to never irritated or impatient. In continuous studies, both on his brain and others with similar conditions, we now suspect this was due to his surgery, as the amygdala were also transected during the procedure. In addition, some of the cortical areas removed were now known to be associated with regulations like hunger and thirst, as well as emotional regulation. His is surely an invaluable case that we have learned countless priceless details from and will continue to do so. Thanks to his willingness to contribute to research, he donated his brain to the Brain Observatory. It may be viewed publicly for free on their website as of 2018. And as such, we continue to learn more and more about memory-damaging diseases like dementia. Now, while Henry's case contributed heavily to our understanding of dementia and memory decay, a trauma-induced case like his doesn't always translate well to genetic or familial diseases. In the category of dementia alone, some examples will include familial Alzheimer's disease. This is the rare form of Alzheimer's which develops as early as the 50s or 60s. Huntington's disease, one of the few purely genetic diseases we have identified, and frontotemporal dementia. At this point, I'd like to discuss Parkinson's disease, though not for the reason you probably think. Rather than being a genetic disease, Parkinson's cases are mostly sporadic or without a known origin. But a different type of damage does appear to have some family-linked traits, trauma due to drug use. In particular, there's a significant connection between the use of heroin and the development of Parkinson's disease. How do drugs come into play with this? Well, this story begins in the early 1980s in San Jose, California. Hospitals found a surge of young people affected by what looked like advanced late-stage Parkinson's disease. Total rigidity, an inability to voluntarily start and stop movements, and resting tremors called bradykinesia. This symptom even responded well to L-DOPA, levodopa, the precursor to dopamine, commonly used as a therapy for Parkinson's disease. It took time, though, to figure out what was happening to these individuals. Some were even diagnosed as catatonic schizophrenics. But once they finally were able to identify what was going on, they found that it was due to a chemical known as MPTP. This was formed during the process of manufacturing designer heroin, but instead of getting its users high, it obliterated a brain area known as the substantia nigra. So while these patients were eventually diagnosed with having what's called drug-induced Parkinsonism and found to have profound damage to the substantia nigra, highlighted in red here, this is a dopamine-rich region within the brain. In this region, dopamine-producing cells are so densely packed that they appear black in dissected tissue, hence the name substantia nigra or black substance. With advanced disease states, up to 70 to 80% of cells are lost in the area, and the coloration is lost. In these addicts, the condition seemed nearly identical to Parkinson's disease. But how we define true Parkinson's versus Parkinsonism then largely gets based on how quickly the symptoms came on and how well they respond to treatment. True Parkinson's, for instance, is slow and progressive, and Parkinsonism may appear relatively quickly in these cases, such as in these cases. Both responded to levodopa therapy, but for different amounts of time. In true Parkinsonism, levodopa works for a couple of years at a time, and in the drug-induced Parkinsonism cases, only worked for a very short transient period of time. And yet there's yet another condition that is also being confused with PD and Parkinsonism, Lewy body dementia. This is gaining quite a bit more attention in the press, especially since the news reports of Robin Williams. This is also further broken down into dementia with Lewy bodies and other Lewy body diseases. But our ability to diagnose is improving rapidly, pinning it down now as the second most common form of dementia behind only Alzheimer's disease. Like Parkinson's disease, there may be a loss of motor control and tremors, but this may or may not respond to levodopa therapy at all. But being able to differentiate between these different forms of motor-based dementia is important not only for planning our treatment options, but getting a clear picture about what is happening in true Parkinson's disease. Now, the research team that identified what are now known as the frozen addicts went on to form a new theory about how this drug-related trauma is contributing to an otherwise age-related decline. It is known as the Cairn-Langston hypothesis, and it suggests that while the substantia nigra naturally goes through degeneration, again, it takes about 70 to 80% cell loss in this area before symptoms even start to appear. We now suspect that toxins in the environment may contribute to that decline and bring the disease state on at an earlier age. The greater the exposure, the more rapid the decline. As much as a single dose of MPTP in one's 30s could lead to the development of Parkinson's disease by the time one reaches their early 60s. The implications of this theory are still being explored, though it has brought us a step closer to understanding another awful disease. It's also raised the question of what else might these micro traumas and small-scale damages be adding up to. Now, by now, it's well known that head injuries contribute to cognitive impairment. We have phrases like, so-and-so got kicked in the head and they aren't so bright anymore. People use "where you dropped on your head" as an insult. A subtype of dementia was also named after boxers, dementia pugilistica. Though there is an old joke suggesting that only the bad boxers got dementia. Red Skelton's classic comedy show, shown here, includes the character Cauliflower McPug, which is also a clever pun based on the cauliflower ears of boxers and McPug being pugilist. Cauliflower McPug suffered from dementia pugilistica and was consistently hearing bells and voids all the time. So how can just a few innocent little concussions affect aging? It turns out this is much more significant than we initially thought. Previously known as dementia pugilistica, the new term chronic traumatic encephalopathy, or CTE, was coined in 2005 when Dr. Bennett Omalu performed an autopsy on famous football player Mike Webster. He found signs of both Alzheimer's and Parkinson's in the brain of a man who was only in his 40s. For context, Alzheimer's does not typically develop until one is in their 70s or 80s, and Parkinson's until at least one's 60s. Yet here is a younger brain riddled with tau pathology, substantia nigra cell loss, as well as global atrophy, shown here as an overall shrinkage of brain tissue. Webster's symptoms were further sporadic and unexpected prior to death, including mood disturbances, such as depression and a loss of temper. He lost his temper so easily that he would wave a gun around near his own family. And supergluing his teeth back in. In one reported case, he even was noted as peeing in the oven. The only explanation that Omalu could find for the extensive damage to his brain was his career, a full life of high-impact sports starting from his childhood. Webster was unfortunately not the only athlete to be suffering the unfortunate effects of compound injuries. In the NFL alone, the suicide rate of affected players is shockingly high. In addition to Mike Webster, Terry Long struggled with depression for 13 years before a successful attempt on his own life. Andre Waters had a seizure on the field while playing and was living in constant physical pain. Strzelczyk suffered a gamut of effects, including memory loss, mood disturbances, and paranoia, and was known to vanish for days at a time. McNeil became the first case diagnosed while still living, though he unfortunately passed at age 55 while institutionalized, unable to remember a phone call from his wife mere minutes before. Duerson was more private about his suffering, so we do not even know how severe his symptoms were. but he did designate upon his death that his brain should be donated to the research of CTE. And there were numerous others that I will not go into here. Suffice to say, the identification of traumatic encephalopathy made a turning point in our understanding of microtraumas as well as depression. Thanks to those who contributed their brains to the study of CTE, we've since learned that the type of injury contributes to differences in pathology. In essence, not all concussions are created equal. Side impacts and rotational blows, for instance, like those taken on by a boxer, can cause something called diffuse axonal injury, shown here, which includes such types of axonal injury as shearing, twisting, and stretching, all of which can damage and kill brain cells. This has an additive effect and typically leads to Parkinsonism symptoms and pathology. Head-on impacts, like those sustained by quarterbacks, on the other hand, are more closely related with Alzheimer's-like dementias, likely due to their direct effects on the prefrontal cortex. Subconcussive hits are those small enough to not cause a full-scale concussion, yet significant enough to cause microdamage, may be more likely in NFL linemen. Yet another type of concussion that affects military veterans includes blast injuries, such as those that occur as a result of explosives. For this, the effects are still being explored, though they are expected to be diffuse and are known to affect emotional well-being. Fortunately, these stories are not all doom and gloom. Despite having survived great hardships, all of the individuals featured here contributed in major ways to the field of neuroscience. Neuroscience would not be where it is without being able to understand those that have survived and recovered from brain injuries. By studying people, we learned what happened, and we can keep this from happening to others. In that regard, we can reinforce yet another age-old idiom: an ounce of prevention is worth more than a pound of cure. Among the preventative techniques now available are balance exercises and adaptive equipment that help reduce the number of falls and accidents in the home. We have improved armor available for military men and women, better helmets that are being used for athletes, and more social services available to people who are fighting addictions to harmful substances. Besides just prevention, we are also getting better at management and treatment techniques. So here's another doctor telling you to eat right and exercise, because it truly is good for your brain as well as your body. I myself will always emphasize the value of tart cherry extract. I always keep a jar of tart cherry juice in my fridge. High antioxidant foods like tart cherries, as well as blueberries, pomegranates, sometimes red wine, in reason, as well as omega-3 fatty acids like fish oil, especially when the two are combined together. There is a combination effect of antioxidants and fatty acids, are beneficial to brain health and might even help delay the onset of dementia symptoms. You can also help keep yourself sharp with good mental exercises. Very often, intensive occupational therapy focuses on tasks that are particularly challenging to you, because those challenges help you to adapt and recover in that area. That is known as task-specific exercise. Basically, if you use it often, you're less likely to lose it. Finally, the relationship between sleep and cognition is surprisingly strong. In fact, there is even a connection between sleep apnea and the severity of Alzheimer's disease, in that improving the quality of one's sleep may help reduce the symptoms of cognitive decline. So ensuring that you get the rest that you need might be just as important as eating right and exercising. Now, if the worst were to happen and we cannot prevent the damage itself, there's still hope to be had. New treatments are being tested every day, including combination therapies. In particular, for Parkinson's disease, there are current tests to use MAOI medications in combination to increase the effectiveness of levodopa. Cell transplantation now is using adult source cells from your own body, because your body cannot reject a cell transplant if it comes from your own body. And of course, intensive occupational and physical therapy that has been effective for many, many people as they work to recover and battle stroke, injuries, and dementia. But first and foremost, don't let anyone ever take away your hope. So I'd now like to open up the floor for any questions you may have, and I have copies of the book available for $25 for those who are interested. Besides the ones we just talked about, This book also features injuries such as Phineas Gage, the famed railroad worker who survived an iron rod passing through his skull for 12 years. Roald Dahl, the children's author, who crashed his plane during World War II. And notable superhero Christopher Reeve, who lived through what is morbidly known as the hangman's fracture. So tell me, what questions can I answer for you? Yes?
I have two. One was on Henry, the first patient you mentioned. He actually had the seizures actually stopped. That was the first question. And the second one is about brain imaging. Hear more about that now. Is that science getting where it can really be predictive for people, where it's worthwhile to get a brain image at some point?
Excellent. So for your initial question, Henry's seizures did get significantly reduced. They did not completely stop, but they reduced to the point where he was able to use a single medication to that, and his intelligence scores actually went up after his surgery. So he was able to improve quite a bit. For imaging techniques, these are getting refined every day. We now have new techniques such as a functional magnetic resonance imaging, where we can see what parts of the brain are active at any given time while you do a task, and diffusion tensor imaging that can show us white matter tracks and are particularly helpful for identifying the origin point of seizures. They are still not necessarily affordable, but they are getting better and better. They have great predictive validity. In many cases, if somebody goes into the hospital with symptoms of a stroke, they will undergo a quick cerebral angiogram so that we can identify the clot, confirm that there is a clot, and introduce the clot buster. Did that answer your question?
It helps, yeah. One reason in the back of my mind is I used to play football in the sandlot, and we were kind of stupid. And so I have no helmets and things like that, and some football players would play too. Mm-hmm. But there's some really rough hits, and you wonder, was there any long-term effects of all that stuff happening? You know, looking at your presentation, and I followed football when Mike Webster was playing, and that's a disaster story.
Oh, yeah.
So you just wonder if a brain imaging would show any kind of risks, that you might have going on inside your brain.
They certainly can. We're seeing, especially with the functional magnetic resonance imaging, that we can see what areas of the brain are getting enough oxygen and sugar, and basically watching the metabolism of the brain as it's being used. And then we can identify any areas that are underused, are not active enough, and that can help us identify these symptoms early enough that we can intervene before they get worse. Yeah. Thank you. Yes?
Are there any particular medicines that taken over time contribute to some of these problems?
We don't know yet. We suspect that some are. In particular, we do know that antipsychotics, very often there is something called the dopamine theory, which helped us understand both Parkinson's disease and schizophrenia, because schizophrenia and Parkinson's seem to be on polar ends of the spectrum. With Parkinson's, we have not nearly enough dopamine. With schizophrenia, we have way too much dopamine. And it turns out that an excess of antipsychotics, while they might help to treat schizophrenia symptoms, we then can end up pushing somebody until they start developing Parkinson's-like symptoms. So we don't know what other medications may contribute to this yet, but so far we do know that antipsychotics may have this type of effect.
And if I put sweetener in the cherry juice, will it have effect?
My excuse is always that glucose is the primary energy source for the brain, so a little sugar can't hurt. Yes?
With the combination of the experimental with the MAOI and the Parkinson's with the levodopa, have they found that they are able to back off on the dose of the levodopa at all, or is it still too early to tell?
From what I've read, it still might be a little too early to tell, but we know that because the levodopa does lose its effectiveness over time, this will at least lengthen the amount of time for which levodopa remains effective. But it's still in its early sort of off-label use for MAOIs, so we still aren't really sure. Yes? Yeah.
So I appreciate how when we talked about HM, we talked about his invaluable contributions to science and our understanding of the brain. I don't know that there have been too many other highly experimental brain surgeries like that. So I'm thinking perhaps the doctor was a little out of line ethically to go poking around like that. Tell us more.
I'm glad you asked this one too. So of course it was 1953, and this Scoville at least admitted the quote, frankly experimental surgery, was verbatim the words he used when he presented the information to Henry. It was probably a little questionable, and there were others in that cohort that when he was doing these surgeries, they had other people with surgeries they tested, but they did a unilateral or one-sided only surgery. And they found that the ones that had unilateral one-side only surgery had more sparing of their memory systems, and those that had more severe memory impairments tended to have existing damage to the hippocampus. So Henry's was really the only case that was purely both sides nice and clean. There are, of course, the ethical questions on that, but I don't think any of the ethical questions get quite as, are you sure, as with the prefrontal lobotomy, which is also featured in the book. Those are cases, of course, of before the ages of neuroleptics and medications were available. The procedure was essentially to intentionally scramble up or sever connections in the brain in hopes that it would reduce errant activity. These were cases, though, too, that it happened so frequently and to so many people, even Rosemary Kennedy, that people active in the field at the time were already saying, maybe not, maybe we shouldn't be doing this. Yeah, I think it was shortly after Henry's surgery that we had developed more stringent ethical standards and a lot more strict, let's try this on rats first. Yes.
So when we think about the future of brain treatment, do you think we will be refining surgical techniques, or do you think we're going to try to keep the skull closed?
We absolutely are refining surgical techniques. There is actually a sort of very distant cousin of the frontal lobotomy called a cingulotomy. A cingulotomy is sort of a last-ditch effort when severe treatment-resistant depression and obsessive-compulsive disorder are just not responding to any kind of treatment, that we very, very carefully and acutely just cut the connections of the cingulate gyrus, and it has been shown to reduce symptoms. But these were all very carefully tested in animal subjects first, passed through surgical techniques, and are given thorough, very, very particular methods. So we use what's called a stereotaxis, which is very, very precise to the micrometer measurement, so we know exactly where we're going, coupling it with neuroimaging, so we know only those 3 little fibers that we want get cut. So we are definitely getting a lot more refinement now. Yes?
One of your slides, you mentioned the importance of cardiovascular problems in brain deterioration.
Yes.
I think this is kind of an unfair, open-ended question, but what if you can kind of speak to the severity of injury from different strokes? Because we all know people who've had strokes. Some seem like they're very debilitating, and others don't seem like they're really effective that much.
Yes.
Just like some insight into that.
Absolutely. Actually, in a couple of my classes, we do discuss the different types of strokes and the severities of each. So there are 3 different types of stroke in general. There is a hemorrhagic stroke, which is a bleed on the surface of the brain. These are the most likely to be fatal and more severe, although the odd part is when somebody survives a hemorrhagic stroke, they're more likely to make sudden dramatic recoveries and survive with little to no symptoms afterwards. The more common kind, up to about 70% of strokes, are ischemic. Those are the ones that are due to a blockage of the blood vessels, and if we identify this quickly enough, you can administer TPA, tissue plasminogen activator, which busts up the clot. And if you catch this early enough, you can basically restore the blood flow to the brain before it can actually traumatically damage any areas. When we don't catch it in time, though, the longer the brain goes without that blood supply, the more severe the damage is. So the cells undergo what's called apoptosis, or a pre-programmed cell death. When they don't get enough oxygen and blood flow, they start to die off. And the longer they go without that, the more of them start to die, the wider the area of damage is. So why the strokes end up so variable is just because there are so many differences in what vessel gets clotted, how quickly can we get there to break up the clot, how rigorous is the recovery-based therapy, and what type of stroke it was in the first place. Thank you. Yes. Oh, yes, I'm sorry. The third type is TIA. Yes, the TIA is transient ischemic attack. So these are sort of temporary blockages, almost like when there is a swelling on the blood vessel that will temporarily cut off the blood flow, and then the vessel will reopen again and restore blood flow itself. Those very often actually get underdiagnosed because a lot of people are not aware that they've had them.
The value of predictiveness, will that help any at all in some of these strokes? Because you hear the generic things about what to eat and what not to eat. I'm just wondering if there's anything a little more focused on, granular to say, hey, you're high risk of stroke or you're not high risk of stroke from imaging.
Yeah, so sometimes the cerebral angiograms can help identify clots and narrowing of the passageways in that. A cerebral angiogram looks at the blood flow throughout the skull. So we can identify an aneurysm. If there's an aneurysm that's about to burst and create a hemorrhagic stroke, we can address that and basically fill up the aneurysm so that it doesn't rupture. If we identify areas that are clotted, we might be able to introduce a stent or clear up the blood vessels or change our diet and exercise so we can improve that blood flow.
That seems highly valuable.
Oh, yes. Yeah.
But I guess it's not something you're commonly do.
Right. Yeah. This the number one recommendation is, of course, to just keep up regular doctor's appointments. Be honest with your doctor too. Like if you've had some excess heartburn or some problems with your blood pressure type of things, keeping up that open communication will help you identify any early signs. Yes.
In that situation, do you consider a carotid duplex more valuable than, like, say, a CT scan or an MRI of the brain?
I'm afraid I can't answer that one. I know I'm not well versed enough in the carotid duplex. Yes.
I don't even know how to ask this question. Is there a relationship, is there an established relationship between certain types of headaches on a regular basis and some of these conditions, say like migraine?
Interesting that you'd ask that too. Migraine disorders and headaches are actually one of the major side effects of traumatic brain injury. So they aren't necessarily symptomatic of the damage itself, but a lot of this damage does lead to the development of chronic headaches. We suspect, at least some research that I've read into in terms of migraine has looked at the blood flow. And so certain treatments for chronic migraine have included Botox injections to sort of kill the nerves that are causing pain, improving blood flow. The number one treatment, of course, being Excedrin medication that is aspirin and caffeine to sort of blast open the blood vessels and address the temporary blood flow issues. Yeah.
Isn't it, I've read that it's hereditary as well? You're predisposed to it?
Yes, I've read that as well, yes.
Do you know anything about that?
I'm afraid I've only read a little bit on the migraines too, but I do know that at least we've found the heritability of migraine disorders, a lot of different work that's kind of going into those migraine disorders, and we're still kind of pinning down what's causing that yet. Yes?
How do you tell if you're suffering from a migraine, how do you tell when it's crossing the line into a TIA?
Sometimes you might not be able to tell if it crosses from a migraine into a TIA. And that's also possibly a contributing factor for why we can't identify those transient ischemic attacks very easily, because somebody thinks, oh, it's just a headache, it'll pass, I have to wait it out. And sure enough, over time, it passes. So you think it was just a headache, when in reality, it might be a little pocket of micro damage. Yes, a very big concern that is definitely of interest to the research field. Right. Yes.
Could you tell us what the current understanding is of dementia, its causes and treatments?
Yeah, so dementia is a very, very wide field. Depending on what type of dementia is diagnosed, it might have a completely different treatment option. For instance, Alzheimer's disease right now is the single most common form of dementia. Its dominant treatments include acetylcholinesterase inhibitors. Goal of these is to reduce the enzyme activity in the basal forebrain and increase the amount of acetylcholine available to the brain, which we know is involved in the consolidation of new memories as well as attention and focus. Other things like cardiovascular dementia may be due to what used to be called hardening of the arteries, and is more likely due to that plaque load and potentially even transient ischemic attacks. So getting improved heart function might improve symptoms or slow down symptoms that way. Does that answer? Yeah. Again, very, very much different depending on what type we're able to identify. Is there anything else that I can answer for you?
Just to confirm, is it kind of true in the vocabulary of the experts that hardening the arteries really is plaque? That's what they're talking about?
I believe so. Yeah. Okay, so thank you all very much for joining me tonight. I'm glad that you could come.